Welcome to the deep dive. Today, we're embarking on what you could call a surgical reconnaissance mission. We are mapping out lung cancer staging, but not just by, reciting the definitions. We want to understand the critical, actionable anatomy that really determines whether a patient can even go to the operating room.
Exactly. I mean, for any clinician in this space, the guide is always the AJCC TNM system. Tumor, node, metastasis. It's essential.
Right. You need it for prognosis, for deciding on systemic therapy.
All of it. And for structuring, those neoadjuvant or adjuvant plans. It's the framework.
But that's the high-level roadmap. And what we know is that the simple overall stage, it often hides the real decision point. A tumor can be, T1, T2, T4, and the actual obstacle is completely local.
And that is the crucial distinction for this deep dive. While TNM gives you the prognosis, it's the tumor's relationship to specific thoracic structures, the airways, the great vessels, the spine, that dictate surgical feasibility.
And the complexity of the whole operation.
Right. We're moving from just the prognosis calculator to the actual surgical planning checklist.
So our mission today is to get into those local features, the things that tell the surgical team and you, the listener, exactly what kind of fight you're really facing. Let's jump right into the T category. Tumor size and extent. The primary T-stage definitions, they seem pretty straightforward on paper. They're based on size. So T1 is 3 centimeters or smaller.
Right.
T2 is, between 3 and 5 centimeters. T3 is 5 to 7 centimeters, or it's already hit the chest wall. And T4 is, anything bigger, or it's invading major structures like the heart.
Those size markers are the baseline for sure. But, the biggest surprises, the biggest changes in thinking are happening right at the bottom of that list, inside the T1 category.
With the smallest tumors.
With the smallest, most localized T1 tumors. Specifically for non-small cell lung cancers that are pure solid and 2 centimeters or less. We've really entered a new surgical landscape for those.
And I think this is where the aha moment is, because for years, we've been taught that the gold standard for resectable lung cancer is a lobectomy. You take out the whole lobe.
Absolutely. That was the rule.
But for these tiny T1 tumors, that rule is being challenged?
It is. And pretty profoundly. Major recent studies have actually shown better patient survival with a segmentectomy compared to a full lobectomy for these very small, pure, solid tumors.
A segmentectomy. So you're just taking out a single bronchopulmonary segment.
A highly targeted anatomic resection, yes.
Wait a second. So we're doing less surgery and getting better outcomes. That seems completely counterintuitive to the whole, maximal resection philosophy.
It does, but the theory centers on functional preservation. The key is that the segmentectomy still has to be an anatomic resection.
Yeah.
You take the tumor, the segment, and it's draining lymph nodes. But you preserve so much more healthy lung tissue than if you took the whole lobe. For a cancer this small and localized, that functional advantage seems to outweigh the tiny oncologic benefit of a bigger resection, and that translates to better long-term survival.
That is a huge clinical nugget right there. For those sub-2 centimeter tumors, less can be more.
It can.
But even in this T1 category, there are diagnostic traps, right? Things that can throw off your initial staging.
Yes, and this is where histology is everything. I'm talking specifically about mucinous adenocarcinomas. They're often T1, but they're a classic diagnostic challenge.
Why is that?
Because they're full of mucin. They have very low cellularity.
And if they have low cellularity, how does that mess up the staging?
It creates a huge pitfall on your metabolic scans. Your standard FDG PET scan works because cancer cells gobble up glucose.
Right, high uptake.
Exactly. But mucinous adenocarcinomas, because of their makeup, they have very low glucose metabolism.
Yeah.
So what you get is a false negative PE scan or maybe just a very faint signal. It make you completely underestimate the disease.
Okay, let's move past just size and talk about the neighborhood. This is where it gets really complicated, I think. When you have a manageable size tumor, maybe a T2 or T3, but it's sitting right next to a central structure.
That changes everything. It shifts the entire decision-making process. Let's start with the airways.
Okay.
If a tumor involves the main bronchus, which is often a T2 presentation, that might require a sleeve resection.
And that's not just cutting the tumor out.
No, not at all. You're removing a whole section, a sleeve, of the main bronchus, and then you have to reconnect the upper and lower parts. You're basically rebuilding the airway.
That sounds like incredibly intricate plumbing. I mean, if you're connecting the main bronchus back to a smaller distal bronchus, there has to be a size mismatch.
There is, and the surgical team has to plan for that. It often requires what's called a telescoping anastomosis.
Telescoping.
Yeah, you sort of fit one end inside the other slightly to manage the tension and get a really solid patent connection.
Okay, now let's move up the airway into T4 territory. What happens when the tumor invades the carina, where the trachea splits?
Carinal invasion. That's a very serious T4 indicator. It often pushes the tumor into the unresectable category because it just means there's deep mediastinal involvement.
And how do you even assess that?
A coronal imaging is key.
Yeah.
You absolutely need to see that relationship in the vertical plane to know if a resection is even theoretically possible.
And what if it's the main trachea itself? I mean, how do surgeons decide where to cut? That's a highway you can't just shut down.
It's T4, and it's incredibly challenging. Resectability is, well, it's very limited. There's so much longitudinal tension on the airway when we breathe.
So if you cut out too much?
If the resection is too long, the risk of a catastrophic anastomotic dehiscence, where the whole repair just comes apart, is just too high.
So on an image, what screams tracheal invasion to you?
We look for a few specific things. Tumor contact that wraps around 180 degrees or more of the circumference, or clear deformity of the lumen, maybe mucosal thickening, anything more than a few centimeters of resection, and the risk goes up exponentially. It's often a hard stop.
Wow. Okay, let's pivot to the vessels. The pulmonary artery, the aorta. How do you tell the difference between a tumor that's just touching and one that has actually invaded? Because that's a life or death distinction.
It is probably the most critical distinction in anatomical staging. Mere abutment, where the tumor just touches the vessel, is one thing. That's often T2. But invasion? That's immediately T4.
So let's take the pulmonary artery. If it's just abutment, what's the surgical plan?
With abutment, you might be able to do an arterioplasty, which is a lung-sparing procedure.
Meaning
Meaning you could do a tangential resection of the vessel wall and then repair it with a patch. Or maybe resect a short segment and do an end-to-end anastomosis. It lets the surgeon do a lobectomy but keep the rest of the lung. But if there's clear, heavy invasion, you have to be ready for a complete pneumonectomy.
removing the whole lung.
The whole lung.
Now, the aorta, the big one. On a CT scan, what are the specific signs that say this tumor has crossed the line from abutment into true T4 invasion?
We rely on really granular imaging markers. You're looking for any irregularity in the aortic lumen itself.
Right.
You measure the length of contact. Anything over 3 centimeters is bad. More than 90 degrees of circumferential contact is another one. But the single most telling sign is the complete lack of a fat plane between the tumor and the aortic wall.
So if that little bright line of fat is just gone.
It's gone. That is a huge red flag for invasion. And if the imaging is borderline, the team might even consider using stent grafts during the operation. But those criteria are what push you from a complex T2 or T3 into T4 territory.
And finally, the heart. Pericardial and atrial involvement. That just sounds like the point of no return.
Well, invasion of the parietal pericardium is T3. A surgeon can usually manage that with what's called an en-bloc pericardial resection. It's complex, but doable.
But the big jump is to T4.
The big jump is involvement of the left atrial wall or any of the intrapericardial structures.
And if the left atrium is involved, what does that immediately mean for the OR setup?
It means the entire surgical team has to be prepared for cardiopulmonary bypass.
So a full cardiac team on standby.
A full cardiac team, because the surgeon might literally need to stop the heart to safely resect the tumor. But, you know, the interesting thing is, even with a T4 status, successful resections can happen. Sometimes a tumor extends from a pulmonary vein right into the left atrium, and it can be carefully peeled off the wall.
All right, let's move up to the very top of the lung. A very specific and notoriously difficult problem. The Pancoast tumor. The superior sulcus tumor.
Yeah, these are defined entirely by their location, right in the lung apex.
And they're challenging because that area is just so packed with critical stuff.
It's incredibly dense. You've got the chest wall, ribs, major vessels, and all the nerve roots of the brachial plexus.
So when is a Pancoast tumor still considered resectable?
Generally, if it's T3, meaning it's involving the chest wall or ribbit, is potentially resectable. But that's only if those other critical structures are spared.
Meaning no invasion of the esophagus, the trachea?
Right. No vertebral body invasion, and crucially, no involvement of the brachial plexus above the T1 nerve root.
So T4 is the point of no return for Pancoast tumors.
T4 is signaled by invasion of the subclavian vessel, definitive vertebral body involvement, or extensive involvement of the brachial plexus. And the unfortunate reality is that less than half of Pancoast tumors are actually resectable when they're first found.
With all that complexity, nerves, bones, soft tissue, how do you accurately stage it? A standard CMT isn't going to cut it, is it?
No. For this, we rely on MRI. It is absolutely the preferred modality for local staging here.
Why MRI?
because of its superior soft tissue contrast. You just need that level of detail to see the extent of brachial plexus invasion. And you also need it to look for marrow signal abnormality inside the vertebral bodies. That's your sign of bony invasion, a definitive T4 criterion. MRI gives the team the blueprint they need.
Okay, let's quickly touch on the N in TNM, the lymph nodes. We've talked about how sometimes you can overcome a really complex T stage with surgical skill. Can you overcome N staging in the same way?
End staging is really the great stratifier. If you have N0 disease, no nodes involved, you're initially resectable. Simple as that.
But if you have N1 or N2?
If you have N1, which is ipsilateral Heller nodes, or N2, ipsilateral mediastinal nodes, the tumor is very rarely operated on first.
Why is that?
Because N1 and N2 disease are prime candidates for neoadjuvant therapy. Chemotherapy, immunotherapy, or both, with the goal of shrinking or wiping out that nodal disease. It's a downstaging strategy.
And if it works, then they can be resected.
Exactly. But there's a line in the sand. A non-negotiable, unresectable stage.
And that would be?
That is N3 disease. So involvement of contralateral nodes or any supraclavicular nodes. N3 just means the cancer is systemic no matter how small the primary tumor is. And surgery isn't the right path.
And I should mention the newest staging, the 9th edition, it refines N2 even further, right?
It does. It splits it into N2A for a single N2 station and N2B for multiple N2 stations, which helps us better stratify prognosis even within that downstageable group.
Okay, moving to the final piece, M for metastasis. Here we're looking at actual metastatic disease, but also, and I find this fascinating, a couple of diagnostic mimics that could lead to a massive staging error if you don't spot them.
The first mimic is something called a sarcoid-like reaction. And this happens after a patient has received treatments, often immunotherapy or chemotherapy.
So the treatment itself causes this reaction?
It can trigger a benign inflammatory reaction, yes.
And on imaging, what does that look like?
Well, that's the problem. It looks like enlarged lymph nodes, specifically symmetric mediastinal and Heller lymphadenopathy. It can even have some mild PD uptake.
So it looks like N2 or N3 disease.
It can perfectly mimic it. So radiologists have to know the patient's treatment history. Pathologically, these are just non-necrotizing granulomas, but mistaking them for true metastases would completely change the patient's entire treatment course.
That's a critical distinction. Now, what about metastasis inside the lung itself? Not through the bloodstream, but through the air.
That's aerogenous metastases. It's the spread of malignant cells through the air spaces, completely distinct from hematogenious spread.
And on an image, that doesn't look like a typical round nodule.
No, not at all. It appears as ground glass or airspace opacities. It looks like it's filling up the air sacs, and the morphology often looks just like the primary tumor. It's very common in mucinous adenocarcinomas.
This brings up a huge clinical question then. How do you tell the difference between these aerogenous metastases and a patient who just happens to have multiple primary adenocarcinomas?
It can look very similar at first glance.
So what's the tell?
The differentiation relies almost entirely on time. Aerogenous metastases show rapid, simultaneous growth on follow-up scans. They're all growing together, and they're growing quickly over a few months.
Whereas multiple primaries.
They're genetically distinct tumors. They're typically slow-growing, often in the apex of the lung, and they'll show clear differences in their size, their density, and their growth rate over time. That rapid, uniform progression is the key to calling it aerogenous spread, or M1A disease.
We've covered a huge amount of ground. Before we wrap, you mentioned one final crucial piece of information that has to be in the report no matter what the cancer stage is.
Yes, this is the interstitial lung disease warning. Radiologists absolutely must report any pre-existing ILD, like usual interstitial pneumonia pattern fibrosis.
And why is that so critical?
Because patients with ILD are at a significantly increased risk for life-threatening pulmonary complications from all cancer treatments, surgery, radiation, and chemotherapy. Reporting it is a mandatory safety step that forces extreme caution in treatment planning. So to sort of synthesize all of this for you, while the overall TNM stage is, of course, the essential prognostic tool for the surgeon, the most critical data points are those hyperlocal, granular anatomical details.
The absence of the fat plane near the aorta.
Right. Or the 180-degree contact with the trachea, or the extent of brachial plexus involvement. These are the real levers that determine resectability.
So it's not just about the size of the bomb, it's about what critical infrastructure it's threatening. I think the biggest takeaway here is that surgical success really depends on the quality of the actionable intelligence you have about that tumor's neighborhood. And now, for our final provocative thought for you to consider, We saw that a tumor involving the left atrium, which is a T4 status, can sometimes be overcome by having the surgical team prepare for a cardiopulmonary bypass.
Hmm.
So what anatomical factor could be present in that exact same patient that would automatically prevent that resection, regardless of how skilled the team is with the T4 status?
Think about the different classifications of lymph node disease we just talked about.
If that T4 tumor also showed N3 disease, say nodes on the other side of the chest, the procedure immediately becomes unresectable, which really emphasizes that while surgical intervention can sometimes overcome extreme T-stage complexity, the extent of nodal metastasis often draws a fixed, immovable line in the sand. Thank you for diving deep with us.